and consequential topics in our industry, physician compensation. I'm thrilled to be joined by Angie Caldwell, CPA and MBA, a nationally recognized expert in compensation design, valuation, and value-based models. Angie is a principal at PYA, where she advises health systems and physician practices across the country on building fair, strategic, and sustainable compensation structures. She's a frequent speaker and a respected voice in healthcare finance, and someone whose insights I think you'll find both practical and thought-provoking. We'll talk about everything from the pitfalls of fair market value to the future of value-based pay, CMS's new team model, and what concierge care is teaching us about the next frontier of physician engagement. Let's get started. Welcome to Pemba On Demand, Physician Leaders Making a Difference. I'm Norm Chapin, your host. Pemba On Demand is produced for physicians seeking professional development. We discuss a wide range of topics on the podcast, including successful innovations in a variety of healthcare disciplines, current issues in healthcare career development, and healthcare leadership. I will be interviewing physician leaders from the U.S. and from other countries, most of whom graduated from the Physician Executive MBA program at the University of Tennessee. The information provided in this podcast is for general informational purposes only and does not constitute professional advice. The views and opinions expressed by the host and guests are their own and do not necessarily reflect the views of the University of Tennessee or any other organization. By listening to this podcast, you acknowledge and agree to these terms. Whether you're sipping your morning coffee, commuting to the hospital, or just looking for a dose of inspiration, we've got you covered. We hope you will take full advantage of these practical, insightful, and relevant discussions designed to help physician leaders get new and build upon existing leadership skills and perspectives. Pemba On Demand will allow you to be an even bigger force for good in healthcare. Angie, welcome to Pemba On Demand.
Thank you. Happy to be here.
It's a pleasure having you here. I've been looking forward to our conversation for quite some time now.
That's terrific. Well, I'm excited as well. I like to share information about different topics, and happy to be here.
Yeah, I think this is going to be a great show. So I know you've been with PYA for a while and that PYA has really deep roots in healthcare. I wonder if you could explain a little bit about what sets your work apart from other companies and vendors in this really technical and nuanced space.
It's a great question. And it really is just that. It's the depth of experience and expertise that sets us apart. So we really use different subject matter experts depending upon the problem at hand and the problem that needs to be solved. And we leverage those experts in a unique way. So we're not just compensation valuation. We're not just regulatory compliance. And so we use the subject matter expertise across all of those areas really to bring a comprehensive solution to a problem, which I think is unique in the industry.
Thank you. I know you've advised health systems across the country. We're here today to talk about physician compensation strategies. What are you hearing most often from physician leaders, from CEOs of healthcare organizations when it really comes down to physician compensation?
A little bit about my background, just thinking about and drawing upon that subject matter expertise. I have about 30 years of experience in healthcare, 26 of which were at PYA. My background includes I was an accountant at a health insurance payer. I was an auditor at another regional CPA firm before coming to PYA 26 years ago. So my audit background is an attention to detail, and just that observing and getting into that detail skill was at use and needed from a compensation valuation. And it's one of those skills that we look for then in building a compensation evaluator, if you will, is that attention to detail and that ability to have some deep critical thinking. And so then when you think about that and then pull it forward into, what's happening today in the industry and, what are people asking for in this space and what are they really struggling with? There are a lot of struggles clearly in healthcare right now, but we hear two main concerns as it relates to physician compensation. One, financial sustainability. So clearly, physicians have the skill and the subject matter expertise and the science and the ability to care and solve problems for patients. And how do we pay them fairly for that skill and expertise in the environment that organizations are in, with declining reimbursement and increasing costs? And how is the entire financial outlook of an organization then balanced? That's a struggle that we continue to hear. And then number two, physician supply and demand. If you look out at the statistics, and if you remember from a couple of years ago, about 5 years ago, there was a great panic. What's going to happen? And all of the studies at that time had the dates of 2025 and 2030. Well, here we are in 2025. And I'm here to tell you and confirm that the supply and demand is an issue. And as the demand for patient care goes up and the physician supply is not keeping pace, and that is creating access issues and it's creating patient care issues across the country. And that continues to be a concern, getting care where it's needed in the specialties where it's needed. So those are the two biggest things that we hear hospital administrators speak about when it comes to physician compensation.
When the hospital administrators talk to you about the supply problem, do they talk about the different levels of work that they're seeing in the workplace from physicians now compared to 15 or 20 years ago?
Yes, absolutely. So the use of EMR systems has completely changed the way physicians work and what is expected from them from a documentation perspective. And so while I believe at the heart of the physician wants to care for the patient, and the everything else is just the extra required for the job, right? The other things that have to be done. And so I think it has changed, and technology is advancing so rapidly as well. The use of that technology in the space, and even how AI is going to come to play for the physician, and how, I'm sure we'll talk about that more in a moment, but how that impacts the physician and the way they work. I think it's changing rapidly and changing every day for the physician.
So when you take all of those factors into consideration, the sustainability of the models, and you mentioned declining reimbursement, and at the same time, we're seeing inflation, we're seeing the cost of living go up for the physicians. So how do you define a quote-unquote good physician compensation model in 2025? What does that look like?
Yeah, so I'll start with kind of the foundation of everything and won't get into a lot of detail, but the rest of my answer is going to depend upon and rely on the fact that any model put forth is, of course, regulatory compliant. It is fair market value and commercially reasonable. So that's given. After that, I would say the best compensation models are designed around the way the physician works. So, for example, a work RVU compensation model is not always the best model. The best models align incentives and goals and missions of the organization with the way the compensation is structured and paid. And again, really how the physician works needs to come into play to create a compensation model that the physician believes in, and the organization can also then support financially from a sustainability perspective.
Are there specialties that the work aligns more closely with an RVU incentive model or an RVU compensation model, and other specialties where there's less alignment between a compensation model that includes an RVU formula?
Absolutely. That's a great question. Hospital-based specialties tend to be less likely to be aligned with a work RVU compensation model, simply because hospital-based specialties, you're providing coverage. It's a coverage-based specialty. And so that physician is not necessarily driving a patient panel, not pulling in, not referring to the hospital or health system per se, but really providing coverage for what is in the hospital or what's going, in the case of anesthesia or the emergency department, what's going through those areas of care in a given day. So while there could be incentives that are perhaps productivity driven, the real foundation of those compensation models are typically and more better aligned when they are coverage based. On the other end of that spectrum, your proceduralists, and I know that we'll probably talk about value-based care here in a few moments and how value-based compensation plays into all of this. But on the other end of the spectrum, your proceduralists, your surgeons, where it is not a coverage-based model, where it is more of a volume-driven business, it's a per-patient business, those are more likely to be aligned with a work RVU compensation model, although times are changing, and that might not always be that way. Norm, my clients and others have heard me say, I love to hate work RVUs. They are wonderful in that they are consistently measured. They are easily derived. They are consistent across patient and across code. So a work RVU for you and a work RVU for another physician somewhere else, they're the same. They bring a wonderful consistency, but CMS will tell you that they never intended for the work RVU to be the basis for all physician compensation. And so while it is what most have leaned on from a compensation design perspective, in fact, I would probably estimate 70% of hospital employed physicians are on a work RVU compensation model, and even probably apply that across all physicians are probably on about 70% are on a work RVU compensation model. It was never intended to be that way. And so at some point, there could be a change to something that's better. And I don't know when that will be, but maybe times are changing.
Thank you for that explanation. I want to move next into, in your vast experience, as you've gone into health systems to try to help them develop compensation plans that will work better in their system, what are some of the most common pitfalls that you find when you start your consulting relationship with those organizations?
Some of it is an assumption, again, that the work RVU model is going to be the model for everyone. That's a pitfall. Two, thinking through how a compensation design change is going to impact the physicians really from beginning to end. When we receive a project for a compensation design engagement, most organizations don't want a compensation design change to change the total dollar value of compensation paid to physicians. They don't want it to have a significant economic impact on the organization. So if you think about that, then just logically, if you're making changes and tweaks within a compensation plan and you have to keep it budget neutral, or the desire is to keep it budget neutral, you could perhaps have, I'm going to say, winners and losers within a compensation plan. And so is the organization then willing to provide the communication and provide the change management required to communicate why things are the way they are, perhaps provide a performance improvement plan, or perhaps a runway for changes to the compensation plan and design over a period of time? So that's a pitfall that we often see. Another one is just creating a plan with too much complexity. Complexity allows an opportunity for errors within a compensation plan. And if a compensation plan gets too complex, you have the administrative cost to administer and actually pay under the plan, and you open yourself up to perhaps additional errors. And then physicians want to know how they're being paid and how the elements of compensation stack up to provide the level of compensation at any time. And so if you create a plan that's too complex, it becomes more difficult to do that. And so creating a complex plan is often a pitfall that we see. And then last, quality and engagement incentives that are kind of that bridge to nowhere, meaning that you've created a quality and engagement incentive that sounds really good or looks really good on paper, but the organization does not have the ability to track or measure it. Or it's a metric that, again, sounds great, looks great, but the physician doesn't actually have control over it and can't effectuate outcomes. And so any of these scenarios that I described, a work RVU model that isn't suited for the physician and the way they work, to a quality metric that's that bridge to nowhere that the physician can't effectuate change or an outcome based upon that, or creating a plan with too much complexity. If all those things are in the same model, it creates a lack of trust, right? And so,
Yes.
and then that creates other problems culturally within an organization.
One of the pitfalls I'm surprised that you didn't mention as you were talking about it is how the health system or the healthcare organization structures the team that looks at changing the compensation plan. What have you seen in that arena, and what do you feel is a well-designed team or cohort of individuals to really shepherd this through the organization?
Yes, you have to have a well-versed team that includes your physician contract administrators, your finance team, perhaps legal should be involved fairly early on, and then a cohort of physician leaders need to be involved, because the physician feedback, and there's so much that the physician needs to do as part of a compensation plan change or a redesign. The physician really becomes the Sherpa in many instances of pulling the plan through and providing that confidence to their colleague physicians that this is the right thing. I've studied it. It's been transparent. It brings that level of trust. And then also understanding from a designer's perspective, a designer needs to understand what the pros and cons are about the current plan, what likes and dislikes, and what the physicians want in a new plan. Now, as in any negotiation or as in any process, if you get to the end and not everybody is quite satisfied, you probably have a really good plan, right? You've probably met in the middle as best as you can from all of the key stakeholders. And then just understanding that squeaky wheels in an organization need to be pulled in early in the process as well, because you have to make sure that the buy-in is appropriate in there. And so then you rely on your physician leaders to communicate with their physician colleagues and their cohort, and really bring back those issues then to the steering committee to make sure that everything is square.
So you don't want to have physicians of like mind necessarily on the steering committee. You need to have some people that may be a little bit frustrated with the current compensation model and may have some ideas about what can make it better.
Absolutely. Absolutely. In fact, I ask for, bring me your physicians that are not currently satisfied with the compensation plan, because we want to hear them, and we want to take that feedback, and to the extent that something can be changed to fix it, we absolutely want to do that.
I think that's a great reminder to all of us. I think most of us are familiar with rolling out what we consider to be a perfect plan, whether it's a change management plan for a new EHR or a compensation model. Yeah, and in the very first meeting, you get a perspective that would have been very valuable to have included in the discussion as you were developing the plan.
Yes. And the more, it can become very complex. So, Norm, I've helped design compensation plans for physician practices of 5 physicians, all the way to physician compensation plans for academic health systems with about 900 physicians and 100 different specialties. And so you do have to make sure that your key stakeholders are involved, you're communicating, and it's interesting that you have to allow time. You have to allow time for different iterations to be worked through and understood, so that the team can really understand what could work, but what ultimately might not work, so that the team together then arrives at the best structure and design.
That has piqued another question in my mind. In general, when you're beginning your consultation with a health system about designing a new compensation plan, how long they should allow for that to go from the beginning until it's finally complete and completely done with the planning stage and ready to roll out?
Yes, so that's a wonderful question. I'll start on the I mentioned 5 physicians all the way up to 900, and I'll couch my answer that way too. 5 physicians, you can do that kind of a compensation plan change probably in about 8 weeks. 900 physicians, you're looking upwards of probably a 2-year process from beginning to end. Now, and why is that? Schedules, timing, understanding that the compensation plan within it may have various structures and different models. So once you get in, first you have to understand and create a baseline for understanding. You have to have a line of sight. Everybody has to understand what you're working from. Number one, you have to understand your market, where are the physicians being compensated within the market today? And what is the organization trying to accomplish? Are they trying to have a budget neutral solution? Is the desire over a few years to increase compensation to a certain level? Do they have a target benchmark, for example, that they're trying to go to? And then categorizing the physicians into different structures. Like we said earlier, this is a good work RVU structure. This is more of a salary or an hourly coverage based model. And then you always have to allow for what I would call key providers in a physician compensation plan. Those providers, perhaps in leadership roles, physician executive roles, that just don't quite fit into the other structures. And so you have to create a structure for them as well. And so it just takes time then to work through all of that and communicate. The communication takes a lot of that time. The math is easy. It's the communication that takes a while. And then thinking through, so once you get the communication done, it's the documentation of it all, right? And it's financial modeling, financial feasibility, and the operational assessment of, okay, if we're going to do this, what are the gaps that have to be then covered? Do we have the systems available to be able to do the plan that we've created? So you're kind of working through all of that simultaneously throughout the timeline of a project like this.
Thank you. This podcast is sponsored by the Physician Executive MBA program at the University of Tennessee, Knoxville's Haslam College of Business. In less than 1 calendar year, this program will equip you with valuable business acumen and leadership development not found in traditional medical school curriculum. Are you ready to join the longest-running physician-only MBA program in the country and a network of nearly 1,000 Pemba graduates? Visit tiny.utk.edu/POD podcast for information about this exciting opportunity. And now we'll return to the episode. One of the things I was intrigued by, and you mentioned earlier fair market value, and there was a webinar that I watched in preparation for this, and you mentioned 5 frequent FMV mistakes. Can you talk a little bit about those mistakes, or maybe a couple of the more common mistakes that organizations make relative to FMV?
Absolutely. My first one would be assuming that the surveys are fair market value. So it's very interesting on this side of things when I might get a call and the call is, Angie, can you tell me what FMV is for a general surgeon? I just need to know what the 75th percentile is. And so immediately I kind of pause and take that breath, because survey is not fair market value. Survey is survey data, and fair market value is based upon the unique facts and circumstances of the market, the physician, the organization, and all of those things combined. And so surveys are wonderful. We love the surveys. But at the end of the day, the survey alone does not determine fair market value. So while compensation plans may target a percentage within a survey, that is the starting place. It is not the end point for determining FMV. So that would be first. Second is not fully considering or recognizing personally performed services. With the proliferation of advanced practice providers, nurse practitioners, and PAs, and how they extend the physician. And again, thinking about the best design plans, understand how the physician is working within the organization with or without a physician extender. and thinking about then how the physician is compensated for personally performed services. So very important. And, we could probably have a whole other discussion about globally billed services and incident to and split shared and how all that's captured and the collaboration between a physician and an advanced practice provider. Exactly. Whole other conversation, but it is one of those pitfalls that we see a lot in determining FMV. So there as well. And then probably my last one would be assuming anything less than the 75th percentile is fair market value. So much so that became the bright line in the industry a few years ago. And I really have no idea why. I think it came from some commentary, an OIG investigation, where the investigation literally commented on the use of the 75th percentile as a threshold for their own investigation and testing of the fair market value of the providers within the investigation. And so because of that comment, then it was inferred, well, gosh, if it's under the 75th, then perhaps it's okay and it wouldn't cause regulatory scrutiny. So much so, again, that the CMS provided some additional commentary later to say, hey, look, guys, that's not what we meant. We use that as a test in our analysis and in our investigation, but you can have a provider being compensated at the 25th percentile and it still not be fair market value. And so that's something that a pitfall that we often see in designing compensation.
So how is fair market value determined? If it's not determined by what people are being paid in the market or keeping it below some type of an arbitrary threshold within that survey, what is the acid test if an organization is looking to remain compliant with the fair market value rules?
Yeah, that's a great question. And my answer would be, and it's a terrible answer, especially coming out of the mouth of a consultant, it depends. And it's facts and circumstances specific. There is no one test that determines fair market value.
Okay.
So you start with the market data, and market data is survey data. It's what the organization itself has paid its physicians, because you create a market for yourself. So your historical compensation and ability to pay a group of physicians a certain way within your market becomes a market data point in that market. What we also, PYA keeps up what we call a market comparable database. So we're constantly looking out across the country of other arrangements that we've reviewed to identify market. So you're always identifying market. And then you're looking at how the physician works, what they're doing, what their expertise is, years of experience. You're moving those things up or down based upon the environment. And then there are some tests that we always apply, but honestly, Norm, I've seen FMV compensation for one individual physician. It might fail every single test, but because of the individual facts and circumstances and ultimately need in the market and the commercial reasonableness argument around compensation, you're able to still support a level of compensation to a physician.
Well, this has been fascinating, Angie. The whole concept of fair market value has always been a bit of an enigma to me. Can you talk a little bit about sign-on bonuses, paying moving expenses, other forms of compensation, and are they tied into the entire fair market value equation as it's being looked at by an external entity?
Absolutely, and they should be. They should be. The difference being that, so sign-on bonuses, again, we could probably have another conversation just about those, increasing rapidly in the present because of the supply and demand issues. And what is different from a evaluator's perspective is that we look at the clawback period on that sign-on bonus to determine the amount that is included in the valuation, in the annual evaluation of that compensation. So, for example, if a $75,000 sign-on bonus is provided to a physician, but the period of clawback is 3 years, so if the physician left after 1 year, they would be required to pay $50,000 back. We're looking at an amortized portion of that sign-on as part of the annual compensation rather than that one-time cash payment. So
Okay.
sign-on bonuses, student loan repayments, amortized
Mm-hmm.
over the annual amount of that, moving expenses, all of that is included in the calculus for determining compensation. Now, benefits, employee benefits. Benefit packages are different across organizations. Some organizations have a better benefit package than others. So, evaluator will look at benefits separate from compensation, and I put moving expenses into the compensation bucket. That's
Okay.
one that sometimes gets put back and forth. But if we're looking at benefits, health insurance, life insurance, 401k, pension, that bucket, we look at that and also test it for reasonableness.
Mm-hmm.
And to the extent that it is in excess of what we would see in the market, we would make an adjustment to our valuation analysis for that to say at some point the benefit package becomes excess compensation, if you will, and we would
Okay.
consider.
Well, thanks, Angie. That was great. And I appreciate you letting me ask some additional questions about FMV because I find it interesting in terms of how it's calculated and how careful organizations have to be when they're designing compensation plans to make sure they don't stray too far outside the guardrails.
Absolutely. It is very important. And there's a concept in the industry, evaluator's judgment. So when an organization chooses evaluator, and when I say that, please know evaluator could be internal to the organization. A third party external valuation firm like PYA, we are pulled in when that additional expertise is needed, but many organizations can do this internally. They
Okay.
do a lot of the work internally. So when that evaluator's judgment is an important concept in valuation. And so while PYA's range might be one thing, another valuation firm might have a different range, and an internal valuation expert might have a different range. The thing is that an organization can't shop. You can't shop until you get the range that you want. You select your evaluator and you use that and you work with that evaluator to make sure that they're understanding all of the facts and circumstances that could increase or decrease compensation as part of that valuation.
Great. Well, thanks again, Angie, for that. I'd like to pivot now and talk a little bit about some of the value-based care and new payment models that are impacting how compensation plans are designed. And you alluded to this earlier, but what progress have you seen with the difficult task of tying physician compensation to quality and to better outcomes?
There has been, honestly, if you look at the numbers, if you look at the data and the dollars attributed to quality and engagement incentives for physicians, it's actually the same as it was about 5 years ago. So we aren't seeing a large increase because organizations are struggling to put more into the quality and engagement bucket. So the natural question about that then is why? Why aren't they able to put more into that quality and engagement bucket? And some of that is one, it's a resistance to change. Two, it is the fact that many organizations are still on a fee-for-service reimbursement model. It is very difficult if the organization is still strongly fee-for-service from a reimbursement perspective to push compensation models to more of a outcomes-based or value-based compensation model if their reimbursement isn't aligned. So that becomes very difficult. And third, it's, as we mentioned earlier, it is the choice of metric and designing of the metrics is incredibly important so that the group of physicians and the providers are not alienated, and also that there is a level of work, effort, and expertise required to achieve that quality metric. In other words, the metric just can't be, please park in this same parking place in the parking lot every day, and that's X dollars to you. So you do have to be very careful in that choice. And then the systems then to measure that and put that through from an administration perspective, that becomes a process. And so overall, I feel like the industry has stalled a bit on increasing compensation in the outcomes or value-based bucket.
It seems like part of the problem may be too, I was just reviewing some data from some of the ACO programs and those kinds of things as we've started to explore new alternative payment models and other value-based models, especially ones that incorporate downside risk. The improvement in quality outcomes and the value to organizations overall, in general, I think has been very modest, very minimal.
Yes, I would agree. And the concept of adding downside risk creates another layer of uncertainty for the organization, and it creates a layer of uncertainty for the physician. And in a world in an industry filled with uncertainty, why would you do another model that creates another element of uncertainty? And so the key is building the team, building the system, and building the program in a way that you feel like your risk of a downside adjustment is minimal. But then we get into the Southern saying, is the juice worth the squeeze for that?
Yes. Well, speaking of new models, one of the new models in the landscape right now is CMS's mandatory episodic payment model, or TEAM. And I know that there's been a lot of focus by PYA on this new model and how it's going to impact organizations. What, in your opinion, should physician executives or hospital executives know about this new structure, and how do they prepare for it?
Yes. So first, TEAM is interesting in that it's supposed to be effective January 1, 2026. There's no strong indication currently that it's not going to be effective January 1, 2026, but we all know there are many changes going on with our government right now, and within Health and Human Services, and within CMS. And so while we believe that it will still be effective January 1st, some do have a question as to whether, there's something perhaps in the proposed rule and the physician fee schedule in the proposed rule that might change that effective date. So I put that out there as an asterisk to say more to come on TEAM. In the meantime, organizations need to continue on as if it's going to happen without fail as of January 1st. TEAM is not applicable to all, so that there are about 700 hospitals across the country where TEAM is mandatory. And for those 700 hospitals across the country, TEAM could have a significant impact. And it could have a significant impact in that, number one, CMS chose the CBSAs for which TEAM will be mandatory in hospitals in areas that haven't participated significantly historically in alternative payment models. So, said another way, we're dealing with perhaps a bunch of newbies to alternative payment models with CMS, number one. So getting used to that and getting into that is going to be perhaps a bigger deal to some of these organizations, not all. Many of these organizations are already very sophisticated, or perhaps a portion of the hospitals within a system are mandatory and some are not. So that's something to think about. Just again, who does this apply for and who does it not? The other thing, number two, is that within TEAM, of course, applies to certain surgical episodes that are high volume, high dollar services within an organization. We're also talking about traditional Medicare, red, white, and blue Medicare. We're not talking about Medicare MA plans. We're not talking about commercial payers. But as an organization, as an executive for an organization, why would you go through the workflow changes, the data changes, the administrative changes required to be effective at TEAM and generate earnings and generate savings under the model for TEAM just for your Medicare patients? Well, you're not. You're going to effectuate the change for all of your patients that are coming through the door. And then that could perhaps create an opportunity with other payers. So if you have already made the changes related to a bundle that create a great outcome and a savings, and you've been required to do it by CMS, why not then try to sell that change to other payers and create another reimbursement opportunity? So that's one thing about TEAM that I think is really interesting. And two, one thing that we're hearing, Norm, that's a little concerning is, one, I've already mentioned it. Well, maybe it's not going to become effective, so January 1, so we're not going to get started. That's a concern. Two, it's all upside the first year. So some organizations are looking at the upside potential in year one and saying, or, well, why do I really care if I'm just going to get upside in year one? And I think my response to that would be, you could have a lot more upside if you were prepared. So by perhaps not being prepared by January 1, you could be leaving dollars on the table. And getting prepared and understanding where your organization is puts you into the driver's seat to being able to select your track under team. And there's a lot, we could have another discussion just about team, but choice of track is very important because if you don't choose, CMS will choose for you. And when CMS chooses for you, there is a greater downside risk after year one.
It's going to be interesting, Angie, to see, number one, I've seen many CMS, especially CMMI initiatives and innovations that have been pushed off years from the initial date that they thought they were going to go live. So it will be interesting to see, especially with all the turmoil going on at CMS and CMMI right now, to see whether that date really sticks.
Yes, I agree. It definitely is a question. And the thing I keep coming back to, and again, goals change. And I'll say the goalpost moves, but CMS had a goal several years ago that by 2030, 100% of traditional Medicare beneficiaries would be part of an alternative payment model. As of January 2025, they were at 53%. They have 5 years. If they are sticking to that goal and not moving their goalpost, I put that asterisk out there, they've got a few years to meet their goal.
Right. Yeah, it's amazing. I remember when that was published and thinking, boy, that's quite a ways away, but it's here. I mean, it's just around the corner.
Yes. Yeah, 2030. Not so far away now.
Not so far away. One of the other things I've been interested to see, maybe call it a trend, is we've seen a lot of concierge medicine practices, direct patient care models coming up. But one of the things that I think is changing a little bit, and I'd like your perspective on it, is the fact that larger medical groups and health systems are now moving into this space and designing concierge practices. I'd like to know how they're viewing their compensation models when they implement a concierge or direct primary care model in their health system or a large medical group.
Yeah, Norm, it's really an astute observation that a lot of health systems haven't gone this direction in the past, that concierge medicine has been more of a private practice opportunity or structure. And I think health systems are now seeing it as an opportunity because it hits on so many problems that they're having. One, the structure seems to combat physician burnout, and that the more high-touch practice, so the physician is able to practice medicine the way that they dreamed of when they went to medical school. So it creates that opportunity. Two, it does create more access in certain markets, which is perhaps a rub, because we can think about the other side of that. But if you are a hospital or health system and your desire is to increase access, and you do have a population of patients that needs weekends and after hours and executive care, and they want all the extra work, then meeting that with this structure is another way to provide access to a community that needs care. And then lastly, I would say that from a reimbursement perspective, concierge medicine creates some predictability. And as we've talked about a few minutes ago, in an industry full of uncertainty, isn't it nice to be able to say, wow, here's something that provides some predictability? We can actually look at the patient panel and multiply it by an amount and come up with, at least 80% of what we think that our revenue will be for this practice for a period. And so it becomes attractive for those reasons.
Okay. We're kind of getting near the end of the episode here. So Angie, I would wonder, as we're reaching the end of the show, if you could answer a question that has been a curiosity of mine for a while, and that is there one myth about physician pay that you wish you could just eliminate permanently, bust it, and convince either administrators or physician executives that's not really an accurate perception about physician compensation?
Sure. Number one size does not fit all. So again, we've talked a lot about work RVU compensation models today and how perhaps they don't apply to everyone. So that is a myth that I would bust, that one model does not fit all. And then number two, what we talked about earlier about salary surveys are not fair market value. They are a starting place. They are a wonderful resource, and they provide access to what the market is saying about a certain specialty and provide information on all kinds of different metrics. But salary does not equal FMV. Those are the two key things that I would like to bust today from a myth and a design perspective.
Thank you, Angie. And another interesting thought that I had as we were preparing for this, I wonder if there's one piece of advice that you would give to a physician executive who's going to be involved in redesigning a comp model in 2025.
Yes. And my answer is going to be simple. And it's about simplicity. Try to the extent that you can to make the structure, to make the plan as simple as possible. There is a tendency in compensation to design, and I'm guilty of it as well. But when you start thinking about all of the different things that a physician does in a period of time, the tendency is to maybe pay for each little individual thing. The goal would be to make a compensation plan as simple as possible and to then leverage within that, leverage those key stakeholders. We talked about bringing the team together and why you want the physician involved and why you want different perspectives in the room. Use those perspectives to create a plan that is simple and that has the support of those key stakeholders.
Great. Thank you. What about trends? What about trends that executives should be watching for most closely in the next 2 to 3 years as they try to design a compensation model that's going to, I guess, survive the test of time?
Absolutely. And I'll answer really thinking about 2 to 3 years. I'm going to answer for today first, which is you have to watch government budgets and regulatory changes. So some of the things that are coming now in the environment that we have today is the Big Beautiful Bill, and how the Big Beautiful Bill could create some issues from a physician visa and immigration perspective. And so that exacerbates the supply and demand issue that we've already talked about and mentioned. Student loan issues and student loan repayment and amounts available for medical student loans could also be impacted by certain elements within the Big Beautiful Bill. And then also research. So the change in research dollars and amounts available for research could impact the physicians and desire to be in the industry. First of all, they might choose another industry. If they want to do research and they can't fund their research, then it becomes a different game. It becomes a different work for the physician. So all of those things are going to be incredibly important and could play on the continued concern around physician burnout that we continue to have. So that would be number one. Two, we touched on it a moment ago, AI. How artificial intelligence is going to impact physicians and their work. So we talked a moment ago about how the best design plans are ones that align with how a physician works. Well, if the physician is leveraging AI and how they're leveraging AI, that's going to change perhaps how the physician works. So how is that going to change an organization's compensation plan? So one of the things that I think about, to the extent, if you think about how a work RVU model is built, and that work RVU, that the foundation of that work RVU model, and I said I love to hate it a few minutes ago, is CMS going to be able to keep up with the changes to how the physician work effort as it relates to AI, and how fast are those work RVUs going to change or not, which is the basis of that compensation plan. I think that becomes a big issue. Is the level of work effort the same?
Yeah.
Because I can tell you that the market for the physician right now, it's so work RVU driven that once we pull that rug out from under, from a measurement perspective, folks have a difficult time. It becomes more difficult to think through the structure and the elements and valuation of that compensation. So that's number two. And then third, financial sustainability. So no one wants to be paid less. And that's one of the things that we didn't talk about in this discussion today, is that physician compensation, generally speaking, while the work effort might move up or down, which might cause a physician's annual compensation to move up or down with it, if you look at same store sales, same work effort year over year over year from an individual, no one wants their compensation to decline because in that scenario. Right. So at what point is exactly, at what point is there a financial sustainability issue that we need to think through? Is there a cap? Is there a compensation bubble that we're going to have to maybe perhaps eventually deal with? And maybe it comes to a head through declining reimbursement, increase in AI, and all these other things that we have to think through from a market perspective and in valuing and designing that physician compensation.
That's an interesting thought. I'd never really thought about it in the perspective of physician compensation and whether we're in a quote unquote compensation bubble or a compensation bubble will develop. And that AI and a compensation bubble could be very threatening to physicians.
Yes. And it's interesting because we've talked about the power of the surveys a moment ago. Mm-hmm. And so we have surveys that are out annually, and physicians look at those surveys and they see the median change. And the first question is, well, I'm better than the median. And so then there becomes this constant measurement against the survey median when there are so many other facts and circumstances that go into determining fair market value of an individual physician. And I'm not blaming, I would do the same thing. It's only natural to look at the bell curve and want to be on the right-hand side of the bell curve. And so, but has the industry relied on the surveys so heavily that at some point we've created an issue for ourselves going forward?
Well, Angie, it has been great having you on the show. This has just been a fascinating conversation. I think this will certainly generate a lot of interest in the listeners. What is the best way for listeners to get more information regarding physician compensation, services that are offered by PYA, or just if they have, if this has piqued as many questions for them as it seemed to for me?
Absolutely. So the best way to reach PYA is our website. And our website address is www.pyapc.com. On that website, you'll see all of our services that PYA provides. And we have an extensive thought leadership library on our website. So there, if you search on physician compensation, you'll find just a number of articles that go deeper into this topic, as well as one of my favorite infographics on compensation design. So it's out there as well. It provides almost a step-by-step guide on how to start a physician compensation design process and all the various elements that an organization would need to consider. And then on that website, you'll find my information as well. You can find me under People, Angie Caldwell, and find my email address and my phone number. And to the extent that anybody has questions on the topics that we've discussed today or other topics, other things of interest, they can reach out to me.
Well, thanks for that information. And I'll include all of that in the show notes for all of you. For those of you that are Pemba alumni, you should know that the University of Tennessee Haslam College of Business is forging a relationship with PYAPC, which is why we wanted to bring Angie on the show. So there may be an opportunity in the future for you to get more information in that way as well. And we'll keep you posted on that. Watch the newsletters for more information to come. But Angie, thank you so much for appearing on the show. You've been a great guest. I've enjoyed our conversation very much.
Thank you, Norm. My pleasure.
That wraps up another episode of Pemba On Demand. A huge thank you to Angie Caldwell for joining us and sharing her deep expertise in the ever-evolving landscape of physician compensation. Today, we explored some of the most pressing issues facing physician executives, from designing fair and sustainable compensation models to navigating the challenges of fair market value, value-based payment, and the regulatory complexities of CMS's upcoming team model. Angie helped us unpack why traditional productivity-based models may no longer serve physicians or systems well, and how concierge and direct primary care models are challenging old assumptions. We also heard how compensation strategy is no longer just about numbers. It's about culture, trust, access, and alignment with your organization's mission. If you're a physician leader thinking about redesigning your compensation approach, today's episode was a powerful reminder. Strategy, structure, and transparency matter more than ever. If you enjoyed the conversation, be sure to subscribe and share this episode with your fellow Pemba alumni and colleagues in healthcare leadership. And as always, thanks for listening. The links to the PYA website and Ms. Caldwell's LinkedIn page will be included in the show notes, as well as links to several other valuable resources. Pemba On Demand is released bi-weekly every other Thursday and available on Apple Podcasts, Spotify, Castos, or Overcast. Please subscribe to the podcast on your favorite podcast player by clicking the subscribe button. Add Pemba On Demand to your podcast library today. I would also appreciate it if you could share the podcast with your friends or colleagues. You can also listen to our podcasts on our YouTube channel, www.youtube.com/@PembaOn-Demand, all one word, no spaces. Please hit the like button and subscribe. Also, if you have any comments or questions regarding this or other episodes, please feel free to add them into the comment section on our YouTube channel. We love hearing from you and are happy to answer any questions you may have. I will add a link to our website and our YouTube channel in the show notes. The website is tiny.utk.edu/Pemba On Demand, all one word. There's no hyphen in that URL. You will find the links to the episodes there. Please also check the show notes for links that were discussed in the show today. Take good care of yourselves and become an even bigger force for good in healthcare.